All right, so this little clip is going to be about acute respiratory failure and ARDS. So you don't need to really know a ton about these two different disease processes, but you do have to have some basic understanding of each, what kind of causes them, how they present. And then ultimately, we're going to talk about non-invasive ventilation and invasive ventilation, because really what we're trying to do during acute respiratory failure and ARDS is really support the patient while we treat the underlying condition. In both of these, there's underlying disease processes that cause these issues. So you have to treat them. So acute respiratory failure, the biggest issue really is impaired gas exchange. We either have hypoxemia or hypercapnia or hypercarbnia, you might see it called. We're going to talk about that a little bit more on the next slide. So causes of acute respiratory failure range from anything like COPD and a COPD exacerbation to pulmonary embolism to pneumonia, asthma, myasthenia gravis, narcotic overdose, right? This can be very acute, or it can be, acute on top of a chronic disease. Diagnosed typically by chest x-ray and arterial blood gases, and the patient's decreasing ability to ventilate and perfuse appropriately. So usually presenting with dyspnea, restlessness, anxiety, fatigue, tachycardia, those are typical signs in somebody who's not oxygenating and perfusing well, all the way up to confusion, lethargy, cyanosis, and ultimately coma related to the lack of perfusion and ventilation. So here you can see on the left, it talks about hypoxemic respiratory failure. And in these patients, we see a PaO2 less than 60% with supplemental oxygen. That in and of itself is telling you this patient is extremely hypoxic. They may have a normal or a low PaCO2 versus our hypercapnic or our hypercarbia, we see elevated levels of CO2, typically greater than 50. That, of course, means that we're retaining acid, so our pH becomes acidic. And you may or may not have hypoxemia in the beginning, and as this progresses, most certainly will have hypoxemia. So what are real treatments for this? CPAP or BiPAP or intubation. So we're going to talk about those things coming up, and mechanical ventilation on another slide set. We also can give medications like bronchodilators and steroids to help open the airway, help decrease inflammation in the airway. That might be really helpful for somebody who has COPD, right? Versus diuretics. That might be really good for somebody who's fluid overloaded, versus antibiotics might be beneficial for the patient who has pneumonia. So again, medications and treatments are really aimed at what is really causing this acute respiratory failure. Non-invasive positive pressure ventilation is the term that we use because it's not invasive. I don't mean that they're intubated and have an endotracheal tube. They have either a CPAP or a BiPAP. So this is often used first if it can be, because it eliminates the need for intubation, and we give it via a face mask or a nasal mask. Patients can even use some of these at home, especially at night during sleep. So let's talk about the differences. CPAP is continuous positive airway pressure. So there, a patient gets continuous pressure through the mask. This can be through a nasal mask. Most typically used for patients who have sleep apnea, because that continuous pressure that's being delivered is what helps to keep the airway and the trachea open and allow the patient to have adequate respiration and ultimately ventilation and perfusion. Versus BiPAP, which is bi-level positive airway pressure, is a little bit more detailed, is typically used in the hospital on more acute patients because we can actually control inhalatory pressure and exhalation pressure. So you can get two separate pressure settings, usually a high pressure setting on inhalation to really force the air in, force the airways open, force the alveoli open, and then a low amount of pressure at the end to just maintain those alveoli from completely collapsing. Respiration can be initiated by the patient or the machine, and usually this mask goes over the face, the nose, and the mouth, and you have to have a good seal because there's pressure being pushed in by the mask. Tolerance is a little bit variable. Usually people tolerate CPAP pretty good. It's not as forceful. It doesn't typically cover their nose and their mouth, versus BiPAP can be a little bit more challenging to be tolerant. But if that's what's going to help save them, obviously we do lots of education. We try to get them to tolerate it because their only other option may be ventilation. Here's some pictures of masks. So on the left, you'd have like a typical BiPAP mask, and on the right, you might have like a more typical CPAP mask. ARDS, acute respiratory distress syndrome, is different than ARF, or acute respiratory failure. ARDS is a very severe inflammatory process. There's over 50 different causes of this, the number one being sepsis. So we see this a ton in the ICUs, especially the medical intensive care unit. This occurs because of the cellular damage that's occurring from the sepsis. We get diffuse alveolar damage equals sudden progressive pulmonary edema. You get a ventilation perfusion mismatch. I want you to look in your books on page, forgive me, I didn't have that. I got it right here. 500, there's a diagram, 27.3. It helps to really understand ventilation perfusion mismatch a little bit. I think it's a good visual representation of that. So take a peek at that. So this sudden progressive pulmonary edema ultimately causes alveoli collapse, 36 to 40% at least mortality rate in these patients. If a patient survives this, we are hopeful that they have regained all function, but they are lucky to survive ARDS. So what are we as nurses going to do to support our patient during ARDS? We, of course, are going to spend a lot of our interventions at treating signs and symptoms, helping with increased perfusion and oxygenation, and treating whatever is causing it, just like when we talked about DIC. So here's a little physiology, pathophysiology kind of walkthrough. Blood is interfacing with non-functioning alveoli, which means they have perfusion of the alveoli, but there's no gas exchange or very poor gas exchange happening at the alveoli. So even if we're forcing oxygen down into their lungs, they're still not oxygenating. So severe refractory hypoxemia, even though we're giving them oxygen, they are not, the gas exchange is not occurring, allowing that oxygen to move across into the blood. And over here it has a really great rundown of how this all occurs. So take a peek at it, take a look at it, and spend some time thinking about what that really means. Clinical manifestations, of course, we're going to have rapid onset dyspnea, hypoxemia despite O2. These are going to occur very, very quickly. You're going to see these signs and symptoms happening, from onset of less than 7 days. This is going to happen quickly. Suddenly, the patient's going to decompensate and be in the intensive care unit on ventilation, on medications to support ventilation as well as perfusion. We often get this chest x-ray that's just a whiteout, we call it. You see it there on the slide. Dense pulmonary infiltrates, and that is very classic of ARDS. Leads to multi-organ failure because we are not perfusing, we are not oxygenating. That's a problem. The patient cannot survive if we're not oxygenating and perfusing appropriately. So management, I already kind of said these things: treat the underlying cause, intubation, ventilation, sedate the patient. We need to deal with fluid management since they're really fluid overloaded in their lungs. Use of PEEP, positive end expiratory pressure in the ventilator. That helps to maintain the alveoli at the end of exhalation open a little bit, so every time they exhale, those alveoli don't collapse and we have to work to open them up again. Nutrition, feedings, we have to give them calories. Their body is working and fighting really hard during this time. Again, remembering the mortality rate of this is huge.